Good afternoon and welcome to What Works in Heart Failure, an update. The Institute for Evidence-Based Care is pleased to offer today's webinar. A few housekeeping details. Continuing education credits are available for this program. Participants must remain for the entire session in order to claim continuing education credits. They must also complete the appropriate session evaluation form for physicians or nurses found on the website and fax it to 732-481-8599 if they are not in a group arrangement. If you are submitting your information individually and faxing it to that number, please provide your contact information for your returning certificate. A few accreditation statement announcements. One nursing contact hour will be provided by the Meridian and May Center for Nursing. Accreditation status does not imply endorsement by the Ann May Center for Nursing. CME credit is also available, and Meridian Health is accredited by the Medical Society of New Jersey to provide that education. Meridian Health designates this live activity for a maximum of 1 AMA PRA credit, Category 1 credit. There is no commercial support for this activity, and speakers have declared they have nothing to disclose. Thereby, we consider this program free of bias. This webinar will be available for viewing for at least the next 6 months for Meridian employees via the webcast website, www.meridianiebc.com. It will be available in recorded form online 24/7 throughout this time in both YouTube and Media Play formats. Availability will begin in approximately 2 weeks after the live broadcast, so please encourage your colleagues to complete the webinar. We will not have time for questions today, but if you have any for our experts, please send them to the Institute for Evidence-Based Care of myself, Kathleen Russell-Babin, at krussellbabin@meridianhealth.com, and we will ensure you receive a prompt response. The overall objective of the program is to discuss current best practices in heart failure as the new guidelines from the AHA-ACC came out in the last 2 months. A few words about our speakers. Our first speaker is Kim McCourt. She is a board-certified adult nurse practitioner and also certified as a heart failure nurse. She graduated from the Ann May School of Nursing with her diploma, completed her BSN at Monmouth University and her MSN at Seton Hall University. Kim is currently a heart failure coordinator at Jersey Shore. She has served in advanced practice roles in heart failure at Jersey Shore University Medical Center since 2002. She has also worked in a private cardiology practice setting. Kim has been honored with several awards, including but not limited to the NJSNA Care Award for Clinical Excellence. Vincent Vivona is a physician in private practice in internal medicine. Dr. Vivona is a diplomat of the National Board of Examiners for Osteopathic Physicians of the American Board of Internal Medicine and of the American Board of Quality Assurance and Utilization Review Physicians. He's a graduate of Hofstra University with a BA in biology. He completed his Doctor of Osteopathy at the University of Osteopathic Medicine and Health Sciences in Des Moines, Idaho. He is also that's Iowa. So, he is also a graduate of Temple University School of Law. He's a fellow of the American Academy of Physicians and a fellow of the American College of Legal Medicine. He has held several medical leadership posts in Meridian throughout the years and is a great supporter of Meridian. I am pleased to provide you access to both of our speakers today, with Kim starting out our presentation. Thank you very much.
Thank you, Kathy. The Centers for Disease Control and Prevention state that although death rates are declining, heart disease remains the #1 cause of death in our country. And looking at the age-adjusted mortality, you can see that Ocean and Monmouth counties rank higher in mortality overall, and rank higher than our state average as well. This slide demonstrates the increased mortality in the non-Hispanic Black community being 34 points higher than the total area, all races and ethnicities. So our total area is 204, and you can see that for Ocean and Monmouth County, we are 238.9. The prevalence of heart disease in Monmouth and Ocean counties is somewhat statistically higher than the United States. Our total area is 8.7, and the United States is at 6.1. So we have our work cut out for us. So it's no surprise that heart failure accounts for about 1 million hospital admissions per year and growing. It is the most common reason for admissions in patients 65 and older. Hospitals are required to submit heart failure data to the Joint Commission, New Jersey Department of Health, and CMS, and were evaluated on the quality of heart failure care through the documentation in the patient medical record. And these results are published and reported to the public. The prevalence of heart failure increases steeply with age in both men and women, and is 25% more prevalent in the African American population. There are quite a few things that predispose us to the development of heart failure, such as untreated high blood pressure, obesity, coronary artery disease, diabetes. And heart failure can be caused by ischemia or lack of oxygen to cardiac tissue. Unexplained cardiomyopathies, peripartum cardiomyopathies. There are certain chemotherapeutic agents that can create heart failure symptoms, and sarcoidosis, just among others. So I want to start with a brief overview because we can't talk about heart failure without first reviewing what an ejection fraction is. The term ejection fraction, or EF, refers to the percentage of blood that's pumped out of a filled ventricle with each heartbeat. It's typically measured by ultrasound or cardiac cath, and normal ejection fraction is 55 to 70%. So this is a little bit of a complicated slide that came out of the new ACC 2013 guideline update. So the EF is considered important in classification of patients with heart failure because of differing patient demographics, comorbid conditions, prognosis, and response to therapies, and because most clinical trials selected patients based on ejection fraction. It is preferable to use the term preserved or reduced EF over preserved or reduced systolic function. So with heart failure, reduced ejection fraction, remember that's less than 40% is reduced ejection fraction. These are the patients that the randomized clinical trials have mainly enrolled. So it's only in these patients that we know efficacious therapies have been demonstrated to date. So there's a subset that's recognized with patients with heart failure preserved ejection fraction who had previously had reduced ejection fractions. So these may be patients that came in and were found to have reduced ejection fractions and were medically managed, and then they've had improvement or recovery in that ejection fraction. So these patients are distinct from those who have persistent preserved ejection fractions, and further research is needed to be able to better characterize these patients. With classifying patients with heart failure, there are two different ways in which we can identify where that patient is at, and that is staging and classifying. So the stages of heart failure are stages A, B, C, and D, which were derived from the ACC AHA fellows. So a stage A is somebody who has high risk for heart failure, but they don't have any structural heart disease or symptoms of heart failure as of yet. So these are patients, who may have diabetes, or they may be smoking or sedentary. Stage B, there is some structural disease, but the patients are asymptomatic. So, for some reason, maybe they have found out that they have a low ejection fraction or some valvular problems, but they've never really actually had a symptom of heart failure to say. Stage C is with that structural disease, and now the patient presents with symptoms of heart failure. And then stage D is that refractory heart failure. With the stages, the patients cannot go between stages A, B, C, and D. Once you're at a stage, you're at that stage. The New York Heart Association functional classification is the classes 1 through 4. Now, patients can go between these classes. So you could have a patient with stage C, class 3, presenting to the emergency room because they have marked limitation in their physical activity. And hopefully by the time they're discharged from the hospital, there'll be a stage C, class 2, or stage C, class 1, where their symptoms have resolved somewhat with treatment. When diagnosing heart failure, you'll see several classical physical findings as well as some typical signs and symptoms of fluid overload. For example, the patient may present with increasing shortness of breath over a week, with some complaint of leg swelling, difficulty lying down. So then you grab your stethoscope and you'll hear their lung sounds. They may have some rales. You listen to their heart sounds. Maybe you hear an S3. Then you get a chest x-ray while they're in the emergency room, and you may see some cardiomegaly and pulmonary congestion, as you can see in this slide where there's the view of a normal-sized heart, and then someone that may be presenting to the emergency room with some of the symptoms of heart failure. So now they're going to be admitted because they have the signs and the symptoms, and they've got an x-ray to prove there's something going on. And as mentioned earlier, we're required to report certain things to Medicare and to the state. And these things that we need to report are called core measures. So one of the core measures that we're obligated to have report is that the patient has an ejection fraction on the chart. This could be an ejection fraction from a year or so ago, but we need to have documentation of what that ejection fraction is. What are we dealing with? What type of heart failure? Is it reduced ejection fraction? Is it preserved ejection fraction? And then if it is a reduced ejection fraction, they want to see that the patient is prescribed an ACE inhibitor or an angioreceptor blocker for that LVSD. We also need to see that is the patient a smoker, or have they been a former smoker? If they've smoked within the past year, then they still do need to have smoking cessation discussed. And then the last core measure is the written discharge instructions. Now, the discharge instructions cover 6 areas. This is our most difficult core measure to meet because of the complexity of education, as well as the challenges of the medication reconciliation, which Dr. Vivona will be discussing later during the session. But here at Meridian, we have standardized the use of this booklet for heart failure education, not only across the system, but also to Meridian rehab centers, nursing homes, and home care to ensure that we are delivering the same consistent message to the patients with heart failure. And this booklet is composed of very good descriptions and a glossary. It discusses the left and right-sided heart failure, eating, low-salt diets, activity, all of the things with medications and the types of medications. So it's a very comprehensive education booklet that is used for our system, and we're lucky to have it. The 2013 ACCF-AHA guidelines for heart failure were just updated, and we were able to incorporate it into this presentation because we were canceled the last time. So we were able to review these guidelines and give you the most up-to-date information for today. Before we start to discuss some of that, this is just a basic review of applying the classification of recommendations and level of evidence. So, for example, a class 1, the patient would benefit greatly, the benefit greatly exceeds the risk, and therefore the procedure or treatment should be done. And then the literature and evidence will go down, towards class 3, where that risk greatly exceeds benefit, and that that is a procedure or treatment that you would not perform on patients. And the level A, B, and C are just where the data comes from, with multiple randomized clinical trials or meta-analysis in multiple populations that are evaluated. So we know that measuring the BNP, or brain natriuretic peptide, is useful to support our clinical judgment for the diagnosis of acutely decompensated heart failure, especially if we're a little uncertain as to the diagnosis. It may be a new heart failure diagnosis or the patient's never presented before and you want to make sure that it's not some other kind of respiratory disorder, the BNP can be helpful to support the clinical judgment. Also, measuring the cardiac troponin is useful because that also establishes prognosis or disease severity in acutely decompensated heart failure. Non-invasive cardiac imaging is also level 1C, and that is that when the patient is presenting to the emergency room in some acute decompensated heart failure symptoms, they should undergo a chest x-ray to assess the heart size and pulmonary congestion, and also to see if there could possibly be any other underlying cause that could be contributing to the patient's symptoms, if there's effusions or a pneumonia. The 2D echo is also something that should be performed for the initial evaluation in the patients that are presenting with heart failure. Now, if they already have a known ejection fraction, that can be used. But repeating that ejection fraction is important when you're looking to see if maybe there's a significant change in the clinical status of the patient. So you may know this patient, know what his EF is, but his presentation may be quite different, and you may want to repeat that ejection fraction. It's also repeated for those patients that have had a problem and they've had a reduced ejection fraction. Maybe they've had an MI and they've been on appropriate heart failure medications for about 3 months. It would be important to repeat the ejection fraction to see if they've recovered from that. You could see an improvement in the ejection fraction, and that's important to know, because if there's improvement, that's great, and you would continue their treatment. But if that ejection fraction is still reduced despite heart failure medication, then those patients would be evaluated for device therapy. Invasive hemodynamic monitoring with pulmonary artery catheters should be performed to guide therapy in patients who have respiratory distress or clinical evidence of impaired perfusion, in whom adequacy of excess of intracardiac filling pressures cannot determine from clinical assessment. If you have a patient that's resistant to diuretic therapy or whose fluid status and perfusion is still resistant despite giving them optimal IV diuretics and medications, they may benefit from having the invasive monitoring. Their renal functioning may be worsening, or they may be in need of parenteral vasoactive agents, in which case you would want to have the pulmonary artery catheter there to measure the treatment for the patient. This is a summary slide. We're going to be talking in more detail about the evidence-based medications used for heart failure with reduced ejection fraction. But this slide came from the ACC-AHA guideline review, and it's really nice because it summarizes the terrific reduction in mortality when you look at the ACE inhibitors or the ARBs, the beta blockers, the hydrolysine nitrate combo. You can see significant reductions in mortality. And as well as the third column over, you can see that patients with evidence-based medications do also have a reduction in heart failure hospitalizations when they're on appropriate therapy. We already talked about measuring that ejection fraction, but what's also important when that patient comes into the hospital is that they're on diuretics, and salt restriction is indicated in the patients with current or prior symptoms of heart failure who have reduced ejection fraction and have evidence of fluid retention. Specifically for patients with reduced ejection fraction, remember that's less than 40%. They should be on an ACE inhibitor unless it's contraindicated, and we will discuss the approved contraindications shortly. But the ACE inhibitors, they alleviate symptoms, they improve clinical status, and enhance the overall sense of well-being of the patients with heart failure. They also reduce the risk of death as well as reduce the hospitalizations, as noted on the previous slide. Angiotensin II receptor blockers should be used if the patient is intolerant to ACE inhibitors. We must remember also that there are specific medications that should be avoided or discontinued in patients who have low ejection fractions, and those are your non-steroidal anti-inflammatory drugs, most of the antiarrhythmic medications, and calcium channel blocking drugs. Those medications we've seen can worsen heart failure symptoms. These are the reasons that are specific and must be documented if the patient cannot tolerate an ACE inhibitor or an ARB. So, for example, if the patient has significant low blood pressure, or if they have hyperkalemia, if they've had angioedema, these are all reasons why the patient should not be on appropriate medication. And that does need to be documented so that when we're reporting this stuff publicly, there is appropriate rationale as to why we're not treating these patients with the evidence known to decrease mortality. When patients cannot tolerate an ACE inhibitor or an ARB, they should be placed on hydralazine and nitroglycerin combination medication, which will be discussed by Dr. Vivona later in the talk. Now, we reviewed the core measures, but here at Meridian, we do take it a step further, and we participate with the American Heart Association Get With the Guidelines, and we work diligently to put best practice measures in place to further improve our outpatient outcomes by decreasing the risk of readmission and decreasing mortality and improving quality of life. So we're not just taking our guidelines and making sure our core measures are met. We're trying to meet more of the best practice for all patients with reduced ejection fractions. So you can see that level 1A evidence for use of one of the 3 evidence-based beta blockers has proven to reduce mortality. In all stable patients should be placed on this. And it is important to note that this is not a class effect. These are 3 specific beta blockers that have been studied that we saw on that previous slide to reduce mortality. They are the following: carvedilol, or Coreg, which is the name brand; metoprolol succinate, which is the extended release medication. Toprol is the brand name. So it's not the low pressor, which is the tartrate. That's a multiple dosing medication. The other is bisoprolol, or Zybeta, which is the brand name, or Zyac. So these medications, or beta blockers, are the ones that have been studied to decrease mortality in these patients with reduced ejection fractions. Now, like the ACE inhibitors and ARBs, if the patient with LVSD is not on one of the 3 approved beta blockers, we need to have an acceptable rationale documented in the chart. So, for example, if the patient has a significant bradycardia, well, then that would be an appropriate reason for them not to be on an evidence-based beta blocker. Or maybe the patient is fluid overloaded, and you may be holding that beta blocker for a short period of time, but that would need to be readdressed at discharge on whether or not the patient can be placed safely back on the beta blocker. There are certain COPDs, such as asthma or allergic reactions, that are also appropriate not to have it on. The one thing that is no longer acceptable is cost. That used to be an acceptable thing that the patient couldn't afford it. However, these evidence-based beta blockers are in generic form, so saying that it's not affordable is no longer an acceptable reason for not having a patient on appropriate therapy. Aldosterone receptor antagonists are recommended in patients who are classified as New York Heart Association class 3 through 4 and who have the reduced ejection fraction of 35% or less, unless it's contraindicated. But this will help to reduce morbidity and mortality, and patients should be placed on aldosterone antagonists for reduction of mortality, but it must be done very carefully because the aldosterone antagonists do work through the kidneys. And so if you have a patient whose creatinine is 2.0 in a female or 2.5 in a male, that would be a contraindication to starting that aldosterone antagonist. because you need to be able to make sure the patient's not going into acute renal failure. Also, it can cause high potassium levels. So you need to be sure that the patient's potassium level is stable prior to putting them on an aldosterone receptor blocker, antagonist, sorry. So it is important to note that although the aldosterone antagonist is beneficial, it has to be prescribed to a patient that you know has stable renal function, stable potassium, and that you know will have active follow-up to have the blood work checked if they're placed on these medications. Routine use of combining ACE inhibitors and ARBs and aldosterone antagonists is potentially harmful and not recommended for patients. It is rare that we see patients on both ACE inhibitors and ARBs, but if they are, then they should not also be placed on aldosterone antagonists as well. At this point, I'm going to turn the microphone over to Dr. Vivona, and he's going to discuss the further best practice treatments and the acute hospitalized patient.
Thank you, Kim. The combination therapy of hydralazine and isosapide dinitrate is recommended to reduce morbidity and mortality for patients self-described as African Americans with a New York Heart Association classification 3 to 4, heart failure with reduced ejection fraction, receiving optimal therapy with ACE inhibitors and beta blockers unless contraindicated. Interestingly, the brand name for hydralazine and isosapide is Bidil. And Bidil, in the FDA approval, used a study which revealed that it reduced mortality in African Americans 43% and actually reduced hospitalizations by 39%. This is just in the African American community. Unfortunately, because of the politically correct philosophy in our country today, a lot of people were saying it was a race-based medication and really did not gain significant acceptance over the past years. The medication does do that. It's been scientifically approved for that with good research. And in all African Americans with reduced ejection fraction, this combination should be used as part of the therapy. Also, interestingly, because of the bioequivalency problems of the generic preparations of hydralazine and isosapide, the actual brand is actually more effective than the generic components that are used separately. Unfortunately, the medication is very expensive, but certainly if you should really recommend at least the component therapy, and if so, if they can afford it, the brand name Bidil. A combination of hydralazine and isosapide can be useful to reduce morbidity or mortality in patients with current or prior symptomatic heart failure with a reduced ejection fraction, who cannot be given an ACE inhibitor or ARB because of drug intolerance, hypotension, renal insufficiency, unless contraindicated. Patients with chronic heart failure with permanent, persistent paroxysmal atrial fibrillation and an additional risk factor for cardioembolic stroke, for example, history of hypertension, diabetes, mellitus, previous stroke, or TIA, or greater than 75 years of age, should receive chronic anticoagulant therapy in the absence of contraindications to anticoagulation. The clinical conditions of hypertension, diabetes, previous stroke, and age are included in what we call the CHADS-2 scoring system, which actually we use for institution of anticoagulation in patients. They have to have, if they have more than one score, they are candidates for anticoagulation. If it's a young male, 45, with paroxysmal atrial fibrillation, with none of these factors, we would not place that patient on anticoagulation therapy. Digoxin, which in my day, in the old days, was used very commonly for atrial fibrillation for rate control, has really not been used as it has because of the ACE and because of the beta blockers and the calcium channel blocking medications. But it can be beneficial with patients with reduced heart failure with reduced ejection fraction, and unless contraindicated, could decrease hospitalizations for heart failure. Patients with chronic heart failure with permanent persistent paroxysmal atrial fib and an additional risk factor for cardioembolic stroke, again, our CHAS score comes into play, should receive chronic anticoagulation therapy, of course, in the absence of any contraindications to anticoagulation therapy. The selection of an anticoagulant agent has now become more flexible for patients with atrial fibrillation, because not only do we have Coumadin, but we have the dabigatran, apixaban, and rivaroxaban. Don't my pronunciations, but the brand names for these are Xarelto, Eliquis, and Pradaxa, and they can be used for permanent, persistent paroxysmal atrial fib, and can be individualized on the basis of risk factors, cost, tolerability, patient preference, potential for drug interactions, and other clinical characteristics, including time in the international normalized rate therapeutic ration if the patient has been taking warfarin. Basically, the benefit is that the patients do not have to go weekly or monthly for a INR. Number two, the diet restrictions that we see with Coumadin in terms of the vitamin K foods, greens, etc., antibiotics, which can increase or decrease the INR, basically is out of the question here, because when you're using the other medications, they are a steady state medication. They hit the anticoagulation cascade at a different point than the Coumadin does. And they are gaining they're gaining popularity among physicians, again, only for atrial fibrillation, not for valvular heart disease. Chronic anticoagulation is reasonable for patients with chronic heart failure who have permanent, persistent, and paroxysmal atrial fib, but are without an additional risk for cardioembolic stroke, of course, in the absence of contraindications for anticoagulation. Anticoagulation is not recommended in patients with chronic heart failure with reduced ejection fraction without atrial fibrillation, a prior thromboembolic event, or a cardioembolic source. Patients with chronic or permanent paroxysmal or new onset atrial fib. In the patient who is discharged from the hospital, must have a documented contraindication if it's not used or prescribed. There must be a reason that the medication linked to the documented contraindication. For example, a patient with unsteady gait, balance problems, may have a fall risk. A patient who's had esophageal varices or other reasons for active GI bleeding may be contraindicated. If the medication is prescribed at discharge, you must document the medication, which medication is, dosage and frequency must be documented. Patients not ambulating, bed to bathroom, by the end of hospital day 2. Ambulating patient 2 times daily, at least 20 minutes is indicated to avoid deep vein thrombosis. Patients with deep vein thrombosis or pulmonary embolism can be present on admission. Deep vein thrombosis prophylaxis may be by medication or devices ordered and initiated by the end of the hospital day 2. Please note that anticoagulants at full therapeutic doses are considered acceptable treatment options for DVT. If not prescribed, you must have a documented contraindication or other reason why not. Device therapy has gained much acceptance for the treatment of congestive heart failure. Implantable cardiac defibrillators therapy is recommended for primary prevention of sudden death to reduce total mortality in selected patients with non-ischemic dilated cardiomyopathy or ischemic heart disease at least 40 days post-MI with a left ventricular ejection fraction of 35% or less, and New York Heart Classification Class 2 or Class 3 symptoms, who have a reasonable expectation of meaningful survival for more than 1 year. Cardiac resequence therapy is indicated for patients who have a left ventricular ejection fraction of 35% or less, sinus rhythm, left bundle branch block with a QRS duration of 150 milliseconds or greater, and a New York Heart Association Class 2, 3, or ambulatory 4 symptoms. ICD therapy is recommended for primary prevention of sudden death to reduce total mortality in selected patients at least 40 days post-MI with a left ventricular ejection fraction less than or equal to 30%, and New York Heart Classification Class 1 symptoms while receiving those who have reasonable expectation of minimal survival for more than 1 year. CRT can be useful for patients who have left ventricular ejection fraction of 35% or less, sinus rhythm, a non-left bundle branch block pattern with a QRS duration of 150 milliseconds or greater, and a New York Heart classification 3, ambulatory class 4 for treatment. CRT is not recommended for patients with New York Heart classification 1 or 2, symptoms and non-left bundle branch block pattern with a QRS duration of less than 150 milliseconds. CRT is not indicated for patients whose comorbidities and or frailty limit survival with good functional capacity to less than 1 year. Recommendations for the hospitalized patient, 2013 recommendations. Risk scores are varied. There are many based on clinical parameters. ADHERE is probably the more popular, but these are all used in terms of patients' outcome when they're admitted to the hospital for congestive heart failure. The criteria that embody these risk scores include evidence for renal dysfunction, low sodium, low systolic blood pressure, new ischemic change of ECG, and positive cardiac troponin, all indicating the seriousness of the disease and, of course, the seriousness of the hemodynamic status of the patient himself. A new onset acute heart failure where a rapid outpatient etiologic workup is not available. Those on IV infusions being actively titrated, significant comorbidities requiring intervention, significant elevated respiratory rate or requiring non-invasive ventilation at the time of entry into the hospital, signs of poor perfusion, and patients with poor response to initial therapy indicated by a lack of urinary output or lack of improvement in vital signs. These clinical parameters essentially will allow us to risk stratify the in-hospital patient as to what the outlook may be. Criteria signifying inpatient management in heart failure patients. We use, again, patients with substantial elevation in natriuretic peptide levels, BNP, 1,000, or non-terminal BNP, greater than 5,000, or borderline low normal blood pressure, be evaluated and treated in an inpatient bed, poor social support, and poor follow-up. These criteria, again, for admission of patients into the inpatient setting. The hospitalized patient, patients being evaluated for dyspnea. The concentrations of BNP or N-terminal prohormone BNP. The N-terminal prohormone BNP is actually a precursor to BNP, and BNP is cleaved off of that, and both of those are measured in the bloodstream, and both are elevated in heart failure. They should be measured in patients being evaluated for dyspnea, in which the contribution of heart failure is not known. Final diagnosis requires interpreting these results in the context of all available clinical data and ought not to be considered on a standalone basis. This is very important in terms of telling a patient has congestive heart failure just on the basis of an isolated BNP elevation with no other clinical findings. Acute coronary syndrome precipitating heart failure, hospitalization should be promptly identified by electrocardiography and cardiac troponin testing and treated as appropriate to the overall condition and prognosis of the patient. Again, a secondary heart failure as a result of acute coronary syndrome and acute ischemia. Precipitating factors for acute heart failure. It is recommended that the following common potential precipitating factors for acute heart failure be identified as recognition of these comorbidities. And it's critical to guide therapy. As stated, acute coronary syndromes, coronary ischemia, severe hypertension, atrial and ventricular arrhythmias, infections, pulmonary emboli, renal failure, medical or dietary noncompliance, all can precipitate acute congestive heart failure. Oxygen therapy and rapid intervention. Oxygen therapy should be administered to relieve symptoms related to hypoxemia. Whether the diagnosis of heart failure is new or chronic, patients who present with rapid decompensation and hyperperfusion associated with decreasing urine output and other manifestations of shock are critically ill, and rapid intervention should be used to improve systemic perfusion. Treatment with intravenous loop diuretics. Patients admitted with heart failure and with evidence of significant fluid overload should be treated with intravenous loop diuretics. Therapy should begin in the emergency room department or outpatient clinic without delay. as early intervention may be associated with better outcomes for patients hospitalized with decompensated heart failure. If patients are already receiving loop diuretic therapy, the initial intravenous dose should be equal or exceed their chronic oral daily dose. Urine output and signs and symptoms of congestion should be serially assessed, and diuretic dose should be titrated accordingly to relieve symptoms and to reduce extracellular fluid volume excess. At times, we need to intensify the diuretic regimen due to either poor response or patient is not really clinically improving. When the diuresis is inadequate and to relieve congestion, as evidenced by clinical evaluation, the diuretic regimen should be intensified using either higher doses of loop diuretics, addition of a second diuretic, such as metazolone, spironolactone, or intravenous chlorothiazide, or continuous infusion of a loop diuretic like furosemide. Monitoring the hospitalized patient. It's very important to monitor and to measure food and intake and output, very important. Effective heart failure treatment should be monitored with careful measurement of food intake and output. Vital signs, body weight, determined at the same time each day. Critical signs, supine and standing, and symptoms of systemic perfusion and congestion. Daily serum electrolytes, urea nitrogen, and creatinine concentration should be measured during the use of intravenous diuretics or active titration of heart failure medications. The daily monitoring of these patients is very important for the nurses and for the physicians in terms of monitoring the patient's improvement overall. There may be subtle improvement day by day, or there may be dramatic improvement by day, but we would not know that unless we were really monitoring what we need to monitor. Preserving end organ performance. In patients with clinical evidence of hypotension associated with hypoperfusion and obvious evidence of elevated cardiac filling pressures, for example, elevated jugular venous pressure, elevated pulmonary artery wedge pressure, intravenous inotropic or vasopressor drugs should be administered to maintain systemic perfusion and preserve end organ performance while more definitive therapy is being considered. Invasive hemodynamic monitoring should be performed to guide therapy in patients who are in respiratory distress or with clinical evidence of impaired perfusion in whom the adequacy or excess of intracardiac filling pressures cannot be determined from clinical assessment. Long-term use of an infusion of a positive inotropic drug may be harmful and is not recommended for patients with current or prior symptoms of heart failure and reduced left ventricular ejection fraction, except as palliation for patients with end-stage disease who cannot be stabilized with standard medical treatment. Discharge instructions for the hospitalized patient. Medications should be reconciled in every patient and adjusted as appropriate on admission to and discharge from the hospital. This is very important, and it's a very difficult thing to accomplish, but it has to be done, and should be done in conjunction with the nurse and the attending physician. Knowing medicines on discharge and counseling the patient on discharge can make all the difference in terms of rehospitalizations. In patients with reduced ejection fraction experiencing a symptomatic exacerbation of heart failure requiring hospitalization during chronic maintenance treatment with oral therapies known to improve outcomes, particularly ACE inhibitors or ARBs and beta blocker therapy, it is recommended that these therapies be continued in most patients in the absence of hemodynamic instability or contraindications. In all patients hospitalized with heart failure, both with preserved and low ejection fraction, transition should be made from intravenous to oral diuretic therapy with careful attention to oral diuretic dosing and monitoring of electrolytes. With all medication changes, the patient should be monitored for supine and upright hypotension and worsening renal function and heart failure signs and symptoms. Comprehensive written discharge instructions for all patients with a hospitalization for heart failure and their caregivers is strongly recommended. Again, we stress that with special emphasis on the following six aspects of care: diet, discharge medications with a special focus on adherence, persistence, and up titration to recommended doses of ACE inhibitor, ARB, and beta blocker medication. Activity level, follow-up appointments, weight monitoring, and what to do if heart failure symptoms worsen. Follow-up appointments or contact with the patient within 7 to 10 days from discharge has been shown to keep possible readmissions lower. Multidisciplinary heart failure disease management programs are recommended for patients at high risk for hospital readmission to facilitate implementation of, and address different barriers to behavioral change and to reduce the risk of subsequent rehospitalization for heart failure. Scheduling an early follow-up visit within 7 to 14 days and early telephonic follow-up within 3 days of hospital discharge is reasonable, and again can prevent readmissions. Use of clinical risk prediction tools and/or biomarkers to identify patients at higher risk for post-discharge clinical events is reasonable. I have put together one case which can drive home the point I've made previously on the slides. A 70-year-old African-American male was diagnosed with essential hypertension, hyperlipidemia, and systolic heart failure, May 2011. He has done well on standard therapy. He now presents to the heart failure clinic for the first time with complaints of intermittent shortness of breath and a night cough. His medical regimen included aspirin 81 milligrams a day, digoxin 0.125 milligrams a day, furosemide 40 milligrams a day, potassium 10 milliequivalents a day, simvastatin 20 milligrams a day, carvedilol 12.5 milligrams twice a day, lisinopril 40 milligrams a day, spironolactone 25 milligrams 3 times a week. Blood pressure on examination revealed a BP of 176/90. There was no jugular venous distension at the time. Lungs were cleared to auscultation and percussion. Heart regular, S1, S2 intact with no S3 or S4 gallop. Extremities revealed no pedal edema. Testing revealed a EKG, normal sinus rhythm with left ventricular hypertrophy. Echo revealed systolic dysfunction and ejection fraction of 38%. Impression: this was an African-American male with systolic congestive heart failure on standard therapy for congestive heart failure. Treatment plan. Other treatment plan indications. The AHEF study did look at that isosapide hydrolysine combination, and that was a study which revealed a 43% improvement in survival and a 33% reduction in first hospitalizations. It is underutilized in African Americans with heart failure, despite the AHEF study and the current guideline recommendations and FDA approval. I would like you to consider, when looking at patients who are African Americans, to make suggestions to the physicians that that type of combination therapy should be instituted in the proper clinical circumstance. Thank you for listening.
Thank you, Kim McCourt and Dr. Vincent Vivona. We're very pleased to have had the opportunity to hear your presentation, and it does bring us up to date on the 2013 guidelines for heart failure as promoted by the AHA-ACC. That last case study also brings home the fact that we oftentimes are not living up to evidence-based expectations, and this is an important reminder for us all to address with our African American population. I'd like to make a reminder at this point that participants must complete the appropriate session evaluation forms, and if you're in group setting, turn them into your group leader, or if you are individually viewing this website and web presentation, please fax it to 732-481-8599, and be sure to put your contact information so that we may return your certificate. Finally, we have another webinar yet coming, and we anticipate presenting to you practitioner orders for life-sustaining treatment, otherwise known as POLST, that went into law and practice on July 1st. This presentation will be by Dr. Amy Freeman, who is the leader in palliative care for Meridian Health. It will be held September 26 from 12 to 1. Thank you for attending our webinar today, and have a great day.